I want to talk a little about using Shockwave for nerve pain. Shockwave isn't something that I started out using for nerves. It's when you're starting out, it's easier to use for plantar fasciitis, for Achilles tendinitis, for other types of like forefoot pain, things like that. After you do that, then I found it was easier to use focus shockwave for fractures, for example. Works well. And now, as I've been using it a little bit longer, I'm using it on nerves. So yesterday, I did two neuromas that someone had in their forefoot where they're having pain. So I used a dorsal approach. I used focus shockwave, very low energy, like 0.05. And then today I had an interesting patient. She's a 67-year-old female. She came in and she had dorsal, the intermediate dorsal cutaneous nerve pain. So with palpation, she had this is her second MRI, and it showed a little bit of scar tissue in that area. I think she had a previous ganglion that popped, and there's some kind of scar tissue. So we did radial all around the dorsal midfoot, ankle region, and then did a shockwave focused really low energy. I'm going to start with 3. So I want to explain a little bit about my protocol in terms of how it's changed over time. With Shockwave, I used to do 3 sessions, then do a 6-week follow-up, and then do another 3 sessions. I did a little bit of coaching with Paul Hobro, and he recommended, and I do find this, it's nice to do 6 sessions now, because usually about the 5th week is where people start to find improvement. So I'm present now when patients are actually getting better, and it's nice to be there when they're going around the corner. What I used to do is when I sent them to physical therapy, they used to start getting better at physical therapy. So my joke is that physical therapy got all the credit. So that is some kind of adaptations of how I'm using Shockwave at this time. Next patient was a 72-year-old man. He had a post-op bunionectomy with a hammer toe repair. He asked me to do his nails, so I did nails. His bunion was still within the global period. You know, one of the benefits of ModMed that we switched to is it's really good at tracking global periods for surgical procedures, for, let's say, routine nail care. So I think the billing component of ModMed is quite superior as I'm kind of getting deeper into it as compared to Athena. He does also have some self-pay callus. So he paid $75 for the callus. I did the nail debridement, and then just the post-op, we got the x-rays. Next was an 80-year-old female. She had a left fourth met stress fracture. So this one was a fracture code. She did a cam boot, and I'm going to see her back in 4 weeks. Next was a 49-year-old female. She had a left... this one had a fourth met fracture. It's been about 4 months. It's not healed, okay? And so for this one, we are going to do Shockwave. So I set up 4 focused only Shockwave. I tend to do, when I'm doing fracture care, I'm tending to do 4 Shockwaves. When I'm doing like soft tissue care, like plantar fasciitis, Achilles, things like that, I'm doing 6. So I did 4 focused only. So that was a good patient because she did not respond to the other treatments. Next was a 70-year-old for bilateral plantar fasciitis, so bilateral sessions. This is number 2 out of 6 for Shockwave, starting to get a little bit better. Next was a 63-year-old female for left arthritis, midfoot. Did ultrasound-guided cortisone injection. So basically with ultrasound, I go to the midfoot, follow the metatarsals back to the cuneiform or navicular cuneiform joints, whatever one is arthritic or there's swelling around it. You can see usually spurring on the ultrasound. Then I drop a little cortisone. I try to do like 1 cc in each of the joints that are painful for this patient. I did an x-ray for her as well. Now this patient also has feeling of the legs feel like wood, and I tend to, when my patients say leg feels like wood, I think of neuropathy, and this patient already is being treated by another provider. I don't focus too much on neuropathy. This is a non-diabetic, kind of like a back pain type of neuropathy. Next was a 80-year-old female she had a left, on her left foot, she had pincer nails, 1, 2, and 5, and they were thickened as well. So she was concerned about, well, should I treat my nail fungus? And at 80, I have to look at these, and she was a very, well-kept 80-year-old, and I said, if you were I said mom, but then I thought, if you're my grandma, I wouldn't treat them. I would just come in and either have me trim the nails or go to a nail salon to trim the nails. She also, in the past, she had a flexor tenotomy on the fourth toe, and she was asking me, hey doc, why in the world did you even do that? And I think patients, they forget why we do things and what was hurting her. And I said, do you remember you had a really bad callus at the tip, or I think it was an ulcer at the tip of the toe? And that's why we did the flexor tenotomy, and it's looking great. That one we did in the office. That's one of my favorite procedures to do, is a flexor tenotomy with an 18-gauge needle. Next was a 39-year-old female. She had a right partial nail avulsion. She had a painful ingrown toenail on one side, on the right foot, on the side of that nail. That was kind of chronic. And then on the left side, she was concerned with nail fungus. And I reassured her. And she was from the Cameroon. She was a very tall patient with big feet, like a size 12 for a female. And I said, are you sure your shoes are big enough? And she came in a sandal, so I couldn't really show her that. But what I tend to do in the practice is I take my shoes off, actually, and I take out my sock liner. And I usually wear lems in the office, and in the lems, I show them like the indentation of my toes. There's about a finger's breadth where the indentation of my big toe is and the front of the sock liner. And I just tell them, I say, what I'd like you to do is I'd like you to take out the sock liner in your shoe, and if your toes go right to the tip of the liner, it's probably too small, and that could be causing some of the toenail pain or toenail changes that you're having. So that's a real easy test. I call that the sock liner test that I do with my patients. Next was a 33-year-old female. She made an urgent care appointment for a possible fracture of her fifth metatarsal base. Now, this was one I did a video on because I'm trying to get more urgent care patients, and this is a prime one. She went there, she got crutches, she got a cam boot, and when I looked at the x-ray, she got new x-rays, she had a little, like an ossicle at the fifth met base, and there was no pain, there was no swelling, and this was one that she could have saved a lot of money coming to see us. So I did a little video, and I'm going to put that on our urgent care page. Just so you know, the urgent care page seems to be working well. We have patients come in every day. And the nice thing on my schedule, it says urgent care, so I can see if they've actually come from that. Next patient was a 54-year-old female for left, second, and third met cuneiform arthritis. And she also had some sinus tarsi pain. And she wasn't really interested in doing cortisone. She actually wanted orthotics. So I scanned her for orthotics. That was orthotic number 1. And I'm going to see her back in basically about 2 months. So with orthotics, what I do is I see them back in 3 weeks, or my staff does, to pick them up, and they get they get a little piece of paper with offering the second pair of orthotics and the break-in schedule, and then I see them 6 weeks after that. Next patient was a 58-year-old man. He had left Charcot, and he was going to be getting a crow boot from one of my other colleagues, and for some reason he ended up on my schedule. He had a right second toe ulcer, and I debrided that. That was the morning. Afternoon, there was a 43-year-old female with left tibialis anterior pain at the insertion. She's a number 4 out of 6 for Shockwave. She brought in her little boy, who I showed magic tricks, just so you know, when little kids come in, I tend to show them magic tricks. If you want to see any of my magic tricks, just ask me. My favorite one is where I take a piece of gauze and I get close to them and I ask them what hand's it, and I kind of move my hand and say, is it the right or the left? And then I do it a couple times, and the last time I throw it right over their head, and they don't know that, and I make it disappear. But the problem is, at the end of the day, I have a whole bunch of gauze in the back of behind my chairs in my office. Okay, so she is doing much better. She's already pleased. She's back to walking, running. She's number 4 out of 6 for this, and this has been going on for her for over a year, so she's getting better faster. Next was a 61-year-old man who had a right nail damage, and I took a nail sample. I don't think it is a fungus. He is super paranoid, So I mostly just talked this patient off the cliff. He was a cash pay patient. He had Mass Health, which we don't take in our office, and he opted for seeing us to do this. A nail sample I sent out to pathology for evaluation, but I really don't think it is. I think he's a little overzealous here, worried about his feet. Next was a 72-year-old man, did a diabetic foot exam. He had some maceration, so I kind of used tendinitis as the diagnosis for that diabetic foot exam. When I do those foot exams, I try not to use diabetes. I try to pick what other type of pathology that they have. Next was a 70-year-old female, and this patient had really bad Achilles, really tight. And so I did my Pelto special, which is a night splint, foam rolling, and morning stretch, and they had a little bit of FHL pain, so proximal to the first met head, and also just some lateral foot pain, and all due to that tightness. That was the main issue. Next was a 59-year-old female. She had a right second toe with blood underneath it, and she was concerned of certainly a melanoma. I was able to trim back the toenail and just show her that it was dry blood, and she also just kind of calmed her down. And she also had some superficial onychomycosis on both great toenails, mostly from taking off her nail polish. So I explained about how to buffer that down. I'm not going to see her back. Next was a 21-year-old female. She's status post fibula fracture. She's still having pain to the sinus tarsi and to the lateral talar dome region, so I'm going to order an MRI for her. Next was a 59-year-old man for number 4 out of 6 for plantar fasciitis. Next one, I'm not going to go in order. I'm just going to do all the Shockwave here. Next was a 33-year-old man for number 2 out of 6 for plantar fasciitis for the right. And then there was a 47-year-old man. He had bilateral Achilles insertional. He's number 3 out of 3 for Shockwave. So let me explain why he's only 3 out of 3. The reason is because a few years ago he had Shockwave and he had 3 sessions. So I find a lot of times what patients want to do is what they did last time. I think they even call this. We had a recent conference here in Massachusetts, and I think it's O'Leary's law or Malley's law. Basically, if you did something one way for a patient in the past, let's say they had a McBride bunion like 30 years ago, do a McBride today. Or do like whatever the same procedure they had last time, do it this time, because that's what they want, because that's what they know. So he had 3 sessions before. Mostly I do 6 now, but I only did 3 because of that. So, and just a reminder, every time I do my last Shockwave session, I do an office visit, because I'm going to talk about what's next for the patient. So whenever I'm doing 3, the last visit, we'll do a level 3 office visit, and then if I'm doing 6, the last session, I'm doing an office visit. So usually, let's say the first visit I'm evaluating and I do Shockwave the first time, so I'll do an office visit, and then the last time I'll do an office visit for them. The ones in between, I don't do an office visit every single time. I know there are some people that, I can do an office visit every time. I don't think I'm really changing my evaluation and management. And the last patient was actually my MVP patient of the day. This was MVP is most valuable patient. So let me explain. This patient, he had a right. So first of all, I tend to find some of my best patients are referred from others. So he came from another family member. 51-year-old man with right cavus foot, very high cavus foot that kind of almost like pronates a little bit, even despite being the cavus. So he's overloading on the lateral foot, has lateral kind of calluses on the right foot, and he has forefoot calluses on the left foot. He has a severe equinus, which I think is causing a lot of that lateral foot pain that he's having. So I did an orthotic for him, and since he has bilateral equinus, I did bilateral night splints. He's going to do foam rolling in the morning stretch. And so because of the bilateral night splints, and he also got scanned for orthotics, that's why he was considered my most valuable patient. So that was the day. For those that are listening, I am working on putting together a 6-month challenge. You should be seeing some emails coming out. If you don't get my emails, you can go to podiatrypracticemastery.com and sign up for anything that I have as a free download there, and you'll get those emails. But we're putting together a 6-month challenge just for people that want to get to their practice over the $1 million mark. And it's going to be a little bit better for those that are around the 600,000 to 700,000. That's how much you're producing in a year. Trying to get that to the $1 million or past the $1 million mark. A little bit harder when you're just starting out because your main focus is going to be on marketing and producing content and stuff like that. Wanted to share a kind of a neat little tip I learned recently. I always like to share new tips. I was talking to a gentleman, and I've been doing these podcasts for a while, and I'm not getting much traction on LinkedIn with these, and I'm not sure why. So if you like this podcast and you listen to it, please just go wherever you're listening and review it. I think that would help me. But in terms of LinkedIn, I send the post every day. And I know probably a lot of podiatrists never looked at LinkedIn because we're all way too busy. But what he recommended is doing some just regular posts on LinkedIn and not doing just links. Because if you do a link to like a podcast, a lot of times they don't show it to as many people. So I've been doing that. And the easiest way is this podcast I record on my phone. So I have a little transcript. And then I just take so on your recording set with the new iPhone now, it transcribes everything. I just put that in ChatGPT on my phone, and it gives me like 3 LinkedIn ideas or 3 LinkedIn like topics. So I'm going to post those in the description. So if you want to see what those are, just so you can get an idea, and then I post that on LinkedIn. So it kind of gives some highlight ideas of the episode. Anyway, those are the things I'm working on. We'll talk more tomorrow. Thanks.